Good morning. Let's go ahead and get started with grand rounds. This morning, let's go. It's my pleasure to introduce one of our chief residents, Dr. Portillo, who is going to be presenting bile duct cancers. Dr. Portillo grew up in Mexico City, went to medical school there, did 4 years of a residency, then came to the United States and was a fellow with Morris Franklin here in town. Spent a year in research as a clinical fellow at Rochester, New York, then came back to complete his residency here, and as of July 1st will be going into practice here in San Antonio at Baptist downtown. Dr. Portillo.
All right. Thank you very much. Everybody can hear me? Thank you very much. I'm going to be talking about bile duct cancers. Did anybody did the ice bucket challenge? I think Dr. Bancico did. Well, these bile duct cancers have the same incidence as the Lou Gehrig disease, about 5,000 new cases every year. Before I start the talk, anybody needs an ice bucket? Hope I won't put you to sleep. So I'll start. No rotten tomatoes allowed, so if anybody has a rotten tomato, please go outside. And let's see if we can make it work. I'm too excited already. All right, so let's start. I don't have any disclosure, no relevant financial relationship or advisory or consulting with any pharmaceutical or medical rep. Sometimes I wish I could have, so I could benefit also as they benefit, but just finishing, so nothing to disclose just yet. I'd like to start with a little bit of historic perspective. This gentleman that you are seeing is a Swiss surgeon, Dr. Courvoisier, which was one of the first surgeons to extract stone from the common bile duct and the gallbladder. His ultimate, remember, I'm guessing the medical students can identify that name for the Courvoisier sign, which he described as a patient had jaundice and a non-tender palpable gallbladder. This condition will be highly associated with a malignancy. And ultimate, I don't know, we use it a lot of clinically, but if you have a patient that has painless jaundice with a palpable gallbladder, you have to start thinking about cancer. Bile duct surgery was one of the things that William Mayo, in this photo you have William Mayo and Charles Mayo. William Mayo was the surgeon, Charles was a medicine doctor. William Mayo was one of the first reported cases of a bile system surgery. He reported his series, and apparently he performed his first case in 1903, and first series was published in the early 1900s. He presented a series of cases of 5 cancers where one of those died and 4 went to survive. So at that time, the mortality rate was 25%. He nevertheless went, and I think at the end of his life, he expired of gastric cancer, which was one of his principal areas of interest later in his career. At those times, I think most of the people will die from infection, but one of the predictions that they did is that people will start living more time, and most at that early 1900s, less population will be dying from infectious sources, and more people will start dying from cardiovascular disease, cancer, and I guess it was a pretty accurate correction when the survival or the estimate life was about 40 to 50 years. Now we're approaching those triple digits, biblical triple digits, which is about 70 to 80 years old. His brother nevertheless died from pneumonia. This gentleman with very interesting eyebrows is You're going to recognize the name, Gerald Klaskin, famous for the Klaskin tumor, which he described a tumor in the confluence of the left and right hepatic ducts. He was an accomplished photographer as Dr. Stewart, an outstanding liver pathologist from Yale. So combining these two knowledge, and this has been motive of even book publication, how he processed his slides and the way he presented this information, having a very keen eye for the artistic composition. As far as the 5 risk factors for bile duct cancer, there is not much reported, but obviously we have to attack the first one, which is the most common, the primary sclerosing cholangitis. And you can see this is a coronal cut of the bile ducts, and you can see the extreme inflammation, the chronic inflammation that is happening in the ducts all the way. You can see in this slide the confluence and then coming down. And the corresponding histological image where this will be the lumen and all the inflammation that is happening. So the key factor is chronic inflammation. It is said that if you have chronic primary sclerosing cholangitis, your incidence of developing a cancer is going to be 1,500 more than the general population, with a lifetime risk of between 9 and 30%. So it's a pretty high risk for developing primary bile duct cancer. And it can be anywhere. It can be intrahepatic, it can be extrahepatic. It is also said that it's worse if you have associated ulcerative colitis. Other risk factors are, has been described, choledochous cysts, frequently asked in the abside. The most common that is associated with cancer is the type 4, just reminding that the type 4 is the one that is extrahepatic, and it can be as high as 30%. The other factors that has been associated, or at least that have been proven to have a tendency towards, is tobacco and alcohol. The other factor has been diabetes, obviously some genetic preconditioning, and I don't know if anybody knows what is the photo of this, and I know it looks like a very fancy fruit that you will buy at Whole Foods, but I guess it's not. Some markets. Yeah, exactly. So this is the liver flukes, which is the other risk factor that has been associated with bile duct cancer. This is more prominent in Asia. The liver flukes has, these 2 lines are the GR tract. All the black things are the uterus, and believe it or not, they have 2 testicles, one anterior and one posterior. So they can have fun. Moving forward to, I guess, the longest, or one of the longest words in the English language, is even, I guess, difficult for me to pronounce in Spanish. But the physiopathology for the developing of the cancer starts with the bile acid estasis on the duct. That stimulation of the acid will promote the expression of epidermal growth factor that has been implied on the tumorigenesis. The upregulation of interleukin-6, which for upside, they always ask this about the acute phase reactant, but in developing of cancer, interleukin-6 will decrease apoptosis and also will increase the expression of tubogranulin, which also has been associated with the tumorigenesis. Has been proven that vascular endothelial growth factor will develop angiogenesis, and this will promote the development of cancer. And the tumor suppression gene P53 has been also associated to have been mutated between 30 to 60% of the cases. So the combination of all those factors will develop cancer. These are really slow. It's a cancer that grows really slow. So before you have any symptoms, it has been duplicated inside the duct for quite some time. And as you will learn later in the talk, that's one of the reasons why when this cancer is found, the prognosis is not as good as any other cancers. And this hasn't been changed for the last century. Let's talk about a little bit of anatomy. The confluence of the right and left hepatic gives rise of the common hepatic duct, which junction with the cystic duct will form the common bile duct. It is said that the common bile duct has 4 portions. So it has the portion that is supraduodenal, the portion that is retroduodenal, the portion that is intrapancreatic, and the portion that is intraduodenal. So 4 portions. As far as the irrigation comes, it's a very interesting area where from the celiac axis you have the common hepatic artery, which give rise of the gastroduodenal. Those gastroduodenals will have a imbricate set of arteries that go sideways. That's why when we do bile duct exploration or we look at the duct, we wanted to do it in the anterior surface because all the irrigation is coming on the sides. That GDA artery will give rise of the anterior superior pancreatic, which is the reason behind, and sometimes ask on NAPSAT, why the pancreas has double circulation between the celiac axis and the SMA. The first branch of the SMA is going to be the inferior pancreatic. And then the classic description where the common hepatic will transform to become proper hepatic and have a left and a right branch and a cystic artery, which sometimes can be also having some collateral circulation or communication to the circulation that comes from the common bile duct. For the matters of this talk, I'm going to divide the common bile duct cancer in 2 types, proximal and distally. I think Dr. Bunia is going to talk about liver tumors in another grand rounds, and I will leave him all the intrahepatic bile duct cancers, and I will focus my presentation for the proximal and distal bile duct cancers. I got this photo from the internet, so I wish it's not any family member, but it's just to illustrate that the hallmark for the disease is the jaundice. As the tumor grows inside the ducts, it's going to produce biliary ectasis, and then it's going to produce the jaundice. This jaundice is going to be a painless jaundice, and most frequently described as also associated with a very heavy pruritus. Some people would lose weight, and that's about 33% of the cases, because you don't need a big tumor to have big symptoms. So the metabolic factor is not quite yet there. Laboratory abnormalities that are associated with this bile duct cancer is as a classic obstructive pattern where you have alphas elevated, you have total bilis, you have direct bili elevation, you can have GGT elevation. Sometimes you can have, for this cancer, also elevation of the CEA and the CA 19-9. And in a general picture, it's going to be a patient with obstructive jaundice. Several imaging studies can be used to diagnose this disease, and sometimes the patient will come and you won't have that suspicious, and you will go the route with several studies. Most of the time they will start with a sonogram, which will prove some intrahepatic duct dilatation and non-specific signs. More specific, if we see the CT scan, the axial cords and the coronal cuts, you can see the amputation, the dilatation intrahepatic, and then what looks like left and right, and then nothing. In the axials, kind of the same picture with the, you can see that the biliary, and this is the arterial phase, so you can see the arteries and the ducts, and then nothing. The MRCP is an incredible sensitive study for this disease, and you can see it left and right, and then that confluence where there's more like a mass obstructing everything and producing a massive dilatation inside the liver. ERCP also can be done, and you can have that diagnosed. In this case, you can see how is proximal common bile duct is feeling, and then they have a catheter go through the what appears to be a stenosis in the proximal aspect of the junction of the left and the right, and then dilatation inside. But sometimes patient can have also some interesting presentations. So this was a case for Dr. Abuyali has referred to him. He was a surgeon that was doing a cholecystectomy. He went ahead, identified all the anatomy, cystic duct, took out the gallbladder, and he decided to shoot a cholangiogram. So when he shot the cholangiogram, the contrast you can see is going to the duodenum, but it's nothing coming above. So obviously he was worried that he had injury, the common bile duct. So that was the reason why this patient was sent to Dr. Abuyali. When the patient came with rains and they started doing this pre-operative studies, they do a PTC, and in fact the contrast is not going distally, but it's also not going to the left and the right. So what Dr. A found at that time is that the tumor, there was a tumor, it was not a bile duct injury, And he was able to resect it because he was on early stages. It was not to the point that it has obstructed the biliary system. So he was able to complete a successful operation and have maybe a better even outcome. So sometimes from bad things, thinking that you have a common bile duct injury, you end up being really happy, that not for the patient, but I guess for the surgeon. When I started preparing this talk, I think I thought of biliary duct cancer as a disease of the 1/3. 1/3 will be candidates for a surgical resection. 1/3 will probably develop some morbidity from that operation, and 1/3 will be alive at 5 years. That's kind of the survival for the 5 years, 1/3. I hope still 1/3 are listening to me. Are we good? Okay. As far as the TNM is going to have resectability implications. So it's very straightforward. It's either the tumor is inside the duct, is a tumor outside the duct and then invading structures, unilateral portal vein, hepatic artery, or invading the main portal vein or bilateral portal vein branches, common hepatic artery. From this, the resectability is going to be decided, and starting with the proximal tumors, in this case, in this example, most of the resection and also the outcomes will be better if you need concomitant liver resection and duct resection. So in this example where you have a tumor in the confluence and then going to the left, the treatment of choice is going to be a left hepatectomy with, it has been proven that recurrence happens in the caudate lobe, so all the resections for the proximal biliary duct tumors will need a caudate resection, so it's going to be left hepatectomy plus caudate resection plus extensive lymph node dissection, because that is going to be one of the key factors for prognosis. All the hepatoduodenal ligament lymph nodes should be procured, and a reconstruction with a Roux-en-Y fashion. In this case, it's going to be to the right duct. In this example, if the tumor were opposite and it was going to the right, and then you have the main left duct free of tumor, then you will do a right hepatectomy with caudate lobe resection, and then you will do the anastomosis to the right duct. In case where the tumor is invading and is going all the way in both left and right, and then you might think that this shouldn't have any surgical resection, well, you can do extended left lobectomy, including the anteromedial lobes. And if conditions are adequate for the patient, if the remnant of the liver is 1/3 again, then most likely the outcomes can be successful and the patient can go and live a normal life. Certain maneuvers can be done certainly to obtain that 30% of liver mass residual, like portal vein embolization has been widely used to promote hypertrophy of the remnant of the liver. And there is certain formulas to calculate with a CT scan what is going to be the liver remnant. So in this case, the posterolateral segments will be the only liver left for the patient, and you can do the anastomosis in a Roux-en-Y fashion. There is certain also consideration, the so-called Hudson loop, where you will leave the limb close to the skin, so it can be accessed, because we know that these anastomosis, they don't last forever, and most of the time will require some instrumentation. So after you do a Roux-en-Y configuration, the instrumentation coming from the mouth is extremely challenging. So coming and having an access direct to the skin can be a good answer. Remember, I said that it was 1/3 of 5-year survival, where there is a single institution, this is the Mayo Clinic experience, where they have found to have a 70% 5-year survival, which hasn't been replicated by any other center, and this is with the liberal use of transplantation. Most of the population that they have transplanted has been patients with primary sclerosing cholangitis, where any resection will be feasible because all the ducts are affected, so anastomosis on an affected duct can be extremely challenging. So most of the subgroup population maybe, and I don't know if that will speak of long-term results, And again, it's only a single institution, only by them has been replicated. Nevertheless, up to 44% of tumor recurrence. It has been said that this patient with primary sclerosing cholangitis, even when it's only confined to the duct and you have a duct and you resect the duct and you have even frozen margins negative, then after the pathology exam, they can come back positive because you can have several tumors in the same bile duct. They have been growing, same physiopathology. The decision to undergo adjuvant therapy for the proximal bile duct cancers, there is no evidence-based medicine to promote or advocate any adjuvant therapy other maybe on the context of clinical trials. In this survival and epidemiology and end results for extrahepatic cholangiocarcinoma, a 32-year-long study, they randomized people from not having any adjuvant therapy versus having radiotherapy, and the outcomes were the same. These were for patients that have a complete surgical resection. So for the time being, for the proximal biliary cancers, it should be only considered in the setting of a clinical trial. And the outcomes have been proven to be better if you have complete surgical resection, if you have the absence of lymph nodes or metastases. The histological grade also has been a prognostic factor. And I think those are the points. But again, 2/3 of the patient won't be able to have any surgical operation, and then palliation is going to be the primary motive. It is said that a patient with bile duct cancer that does not or cannot undergo operation will have a median survival of 4 to 5 months. The addition of chemotherapy can prolong that to 12 months. Still, the obstruction, have a mechanical obstruction, so most of them will need some kind of relief of that pressure, especially because it's said that the pruritus can be life-limiting. The percutaneous drainage can be one option for some patients. They said that it's a better option, surgical option, is the so-called segment 3 hepatojejunostomy, which going into the liver and seeing the segments, for the student, the caudate, the number 1, the left lateral lobes, number 2, number 3, the medial, left medial, the number 4, the anteromedial superior inferior, and the posterolateral superior inferior. So you have the falciform and you retract the falciform, you will incise that segment 3, you will identify the blood vessels, you will need a needle to puncture and see what is the duct, what is the artery. Sometimes it can be confusing. Once you identify that duct that is coming to that segment 3, you will open up, get your root limb, and do the anastomosis. And that's a very durable and appropriate palliative procedure. I haven't done it or seen it here, but it's been described in the books. Now, moving forward into the distal bile duct cancer, they tend to behave more as the pancreatic bile duct cancer because of the anatomic relationships. And talking about distal bile duct cancer, obviously the treatment of choice is going to be the Whipple procedure, the pancreatic duodenectomy. And when I was preparing for this talk, it was interesting to find that there is a little bit of controversy about why it's called the Whipple procedure. And it seems that that procedure was described in the late 1800s by an Italian surgeon from Bologna, Alessandro Codibilla. After his first description and even personal communication with another German physician, Dr. Kausch, which trained under Dr. Mikulicz, the later German surgeon went to describe and publish a series of cases. And after those two experiences, Dr. Whipple refined the technique, and I guess the outcomes got better. I don't know how in history it remained as the Whipple procedure and not the Codibilla or the Kausch procedure. But, and I'll talk more about the Whipple procedure steps and a little bit of how the macroscopic specimen looks like. This is a busy slide, but I just want to show you how things are changing. It's not only the TNM that I already talked about, the T for the tumor, how the tumor is in the duct or is invading adjacent structures. Now the focus is more global, and you can see that now the new proposed classifications include the histological grade of the tumor. It includes the TNM. It includes the margin, talking about the margins, specifically for the Whipple resection. Every single one, I'll show you slides about the SMA retroperitoneal and uncinate margins, posterior margin, that portal grain group, the pancreatic neck, the bile duct margin, enteric margin, and then the absence or presence of lymphatic, vascular, or perineural invasion. So it's a more global that will give all the information, and this will change, and I guess also for a matter of studies can have a very good implications. I found this was a paper that was sent to us when we were, I guess, interns or second years, and it was a pretty interesting paper where they deconstructed the Whipple into 6 clockwise steps and 4 counterclockwise steps. So for the students, so you can understand this is a very big operation, but it can be understood in this way. Starting with the Cattell branch maneuver to mobilize that colon, hepatic flexure, taking it out of the way. Continue mobilization of the duodenum, a full, complete Cocker mobilization. Moving forward in the clockwise fashion to the porteparis, doing a pretty nice lymph node dissection of all the porteparics and identifying the structures, then moving to the transection of the stomach, which has also been proposed as several variants, preserving or not preserving the pylorus, depending on what kind of operation you're doing. Then continuing to the transection of the jejunum, distally to the Treats ligament, mobilization of that segment below the mesenteric vessels, and then finally with the transection of the pancreas. So you have a lot of structures that have been transected. For the reconstruction, 4 counterclockwise steps, starting with the pancreatico-jejunostomy, moving forward to the choledocho-jejunostomy, moving to the gastro-jejunostomy, and then some people will advocate either placing of FCJs, G-tubes, and obviously wide drainage. I'll stop a little bit here to talk about surgical technique. Remember I was talking about that SMA retroperitoneal margin, because it's very close continuity to the uncinate process. It is said that this is one of the most important technical aspects of the operation, to be very extensive, to be very meticulous, to take all that areolar tissue that is behind, above the SMB, SMA, including even sometimes the adventitia of the SMA, to procure a pretty proper pathological specimen. It has been learned from the pancreatic cancer that when the tumor appears to be invading the SMB, resection should be also completed, should be attempted either in the fashion of a vein patch or a vein bypass. It has been proven, at least for pancreatic cancer, and we can assume that this is also true for biliary duct cancer, that the additional vein patch or vein resection won't affect or won't elevate morbidity or mortality of the case, and then longevity has been also proven and had similar outcomes where patients that didn't require any vein resection. Nevertheless, when macroscopic evidence or at least suggestion that the vein is involved, it is only 2/3 of the patients that actually have histological proof of this. And also of those 2/3, only 2/3 will have negative margins. So once that margin is compromised, you have at least maybe 2/3, even with the vein resection, of obtain a complete surgical resection, R0. For the students, the portal vein, the junction of SMB, splenic vein coming behind. In this aspect, you can see that the pancreas has been transected, so that's why we can see it. The SMB and the origin of the portal vein is right about that neck of the pancreas, so it's posterior. All right, I'll show you some macroscopic pictures. So again, talking about that important SMA margin, the so-called portal vein group, the neck of the pancreas, so the very important margin that is in continuity with the retroperitoneal. Retroperitoneal margin, SMA margin. So it's customary that you will take out the specimen, call the pathology into the room, and mark the specimen in the room and show them what is what, because it can be confusing. So we do this inside the OR, and then they can take the specimen and do further exam. It has been said also that the bile duct a margin is a very important one, especially for distal ones, because you can get more. You can go higher. So they have to really tell you if that margin is free of any tumor. In this case, for bile duct cancer, the pancreatic margin is not as important, but also there have been proposed several ways of processing of the specimen, not only doing the classical slice, also doing radial margins for most of these margins. As far as outcomes, for the proximal biliary cancer, remember I said it's the disease of the 1/3, about 1/3 will be alive at 5 years. This is the Johns Hopkins experience, Oliviera's 5-year survival rate of only 23%. It was in about 250 patients. What is interesting is when Japanese Murakami experience reported his survival rate, for very selected patients, about 70 patients, he found that positive margins make a big difference, 8 versus 60, and the presence of absolute lymph node disease makes a big difference, 18 versus 46%. So again, we come to the same conclusions. Tumor size, less or larger than 2 centimeters, the presence or absence of lymph node disease, and the presence or absence of metastasis. For these distal bile duct tumors, the European Study Group for Pancreatic Cancer, the subgroup for bile duct cancer, they found that when they randomized patients where complete surgical resection was done to nothing or a combination of chemotherapy, there was no difference in outcomes at 5 years. Nevertheless, the MD Anderson experience, they approached this differently. They compared patients where complete surgical resection was accomplished and nothing was done versus patients that they didn't have complete surgical resection or they were R1 or the presence of lymph nodes. When they give chemotherapy to those subgroups, the outcomes at 5 years were very similar, which will make you suggest that there is a certain population that should benefit from chemotherapy. Still, there is lack of prospective and really large randomized studies because this is not a common disease. But I think if this were to happen to one of my family members, I will advocate for certain conditions that adjuvant therapy should be indicated for this distal bile duct cancer. Not so much maybe for the proximal, but for the distal. And even then, maybe we can extrapolate that it's the same disease process, so it could also potentially have a benefit for them. Nevertheless, 2/3 of the patients won't be amenable for any surgical operation, so palliation will be indicated. So in this advanced biliary cancer O2 trial, they proved that the addition of chemotherapy can increase the survival from 8 months to almost 12 months. So it's about 50% more survival, but it can be a big difference for a patient that otherwise he doesn't have any other surgical correction. So I will end the talk having some conclusions. So the bile duct cancer are very strange and uncommon disease, 5,000 new cases every year. We can safely say that is a 1/3 disease. 1/3 will be actually operative candidates. 1/3 will go to survive at 5 years, which is low, but that's the current status. The addition or no addition of adjuvant therapy is going to be dependent of the complete surgical resection or the presence or absence of lymph node disease. There is certain palliation that can be accomplished with the chemotherapy or even surgical. And I will finish my talk just showing one slide. This is the original photo from the original Mirizzi paper where he proved his Mirizzi syndrome. If you look at the previous images that I showed you, it kind of looks very similar. And this is just to remind everybody that even though bile duct cancers are a rare disease, they're also benign disease that can mimic them, and you have to be aware of those. And with this photo, I will gladly take your question. Thank you very much.
Guillermo, nice talk. When you say 1/3 survive 5 years, is that 1/3 of those that are resectable?
Yes.
Not 1/3 of all comers?
No, it's only the ones that underwent, so it's 1/3 of the 1/3, I guess.
Yeah, because the ones that are unresectable have a pretty dismal prognosis, almost uniformly.
It's worse for the distal than the proximal, but yeah, the median survival rate is no more than 5 months. Yeah. It's funny that the topic is bile duct cancer, even though the most common bile duct or biliary system cancer is in the gallbladder. So that will give you a little bit of perspective. I guess I've seen one gallbladder cancer in my whole residency, and so it's even more common in gallbladder than in the bile ducts.
Dr. Aubergine.
Thank you for the nice talk. I mean, just one thing about those Claskin tumor, I had a particular interest. We had a series we reported in New England Surgical. The Claskin tumors, the histology makes a difference. There's 4 types. There's a papillary, nodular, infiltrating, and scurous. The papillary, they are very slow growing, like in breast. You can have a recurrence, but you might not detect it. And I had a patient who lived with recurrence for at least 3 to 4 years. It was a papillary. The worst are the scurous and the way they spread, they don't spread throughout. There's no hematogenic spread, but local like a basal cell. They infiltrate ducts, neighbor vein, and artery. So they may linger for a long, long time before you get to them. And as you said, chemo does not work, radiation does not work. The Japanese now, they're using seed. I don't know where are they with their seeds.
I didn't find anything. I guess the 32-year-old or year prospective study, the radiation didn't.
I'd like to ask my neighbor here, the transplant in sclerosing cholangitis, when do you decide to transplant those people? Do you base your knowledge on the phosphatase alkaline, what's over 1,000? How do you decide when you're going to transplant?
I think, once you've got sclerosing cholangitis, the chances of developing cholangiocarcinoma are very high. And so, we basically evaluate those patients for transplant.
They ask you always that on the upside, recurrence rate after transplant plus biliary for primary sclerosing cholangitis for transplant, and it's the same for alcoholism, 20% recurrence rate.
You talked about multiple tumors. Dr. Cruz, is it multiple tumors or are there skip lesions? We've resected these and all of a sudden we take a little bit more and we find another tumor.
They are multifocal, there's no question. They are, so you have to keep an eye, and be vigilant. Follow them with CA-19-9, re-X-ray them, examine them, and so forth. But they are, some of them are, particularly these, the infiltrating, they'll recur quickly. But the papillary one, they are the sneaky one. You have to follow them, carefully and see when they're going to show up again.
Any other questions for Dr. Portillo? You talked about ERCP, but actually, prior to that, we're kind of spoiled these days with our interventional radiologist. That was a technology that came along in the 60s. Prior to that, intraoperatively, now I'm speaking historically, not that I was present at the time, and I'm not looking at you, Dr. Pastano, is that the surgeon was faced with decompressing the biliary tree, and they jam a huge tube into the bile duct and bring it out the liver. I think it was called a U-tube or something.
Oh yeah, Dr. A showed me a picture of that procedure.
You mean the U-tube?
Yeah.
Terre Blanche, South Africa. Yeah, I met Terre Blanche a long time ago in California, and he still uses it, but it's messy. It's terrible. The patient hates it, and they bile all over the place. It's much easier, to do a segment 3 bypass, like you show you, segment 3 bypass. It's not difficult because segment 3 dilate when the hilum is obstructed. And you do hepatotomy. You follow the round ligament. There's a vein, you ligate it across, and here you have a duct that you put your needle, inject, you get a cholangiogram, and then you plug your Roux-en-Y there.
But the advent of percutaneous transhepatic cholangiography really made a big difference for palliation. Yeah. And then along came stents.
Yeah.
Yeah. All righty, thank you.
Thank you very much.
Dr. Stewart said you can stand up and stretch, but don't leave.